All
Yeah.
right. Yeah, wonderful case, Judy. Actually, we published in ophthalmology a hypothetical mechanism based on basic science why that might be occurring. So that's a good, I think a good, we don't have a causal relationship, but I think your comments were spot on. So thank you for giving that talk. And I'm going to talk about not a diagnostic dilemma, but more of a therapeutic dilemma. And this is a long-term outcome for a patient with CSR that I managed. And this is his history. He's a Hispanic male. He was diagnosed with central serous in both eyes back in 2013. He has cataracts in both eyes, as well as visual acuity in the right eye was 2300. His left eye is 2025. On the OCT, you could see there's sort of a thickened choroid, maybe. There's sort of that stalagmite appearance where you see this material growing below the retina. You see subretinal fluid present as well. And interestingly, in the right eye, he had also these sort of deposits present here and subretinal fluid present with good vision in that eye. And so it's interesting. Jay and I have talked a lot and done. Jay is a luminary in the field of central serous. So this is like presenting to the gods of central serous, but it's more of a therapeutic dilemma than it is a diagnostic dilemma in this patient. Their fluorescein shows you just basically some leakage, which is in and around the fovea that you can see here. There's no real peripheral leakages and nothing that is really obvious from the standpoint of a neovascular component. Here's the left eye again showing you peripheral areas of leakage in this same patient in the early and late frames of the fluorescein angiogram. And so I just thought I'd open it up for comments to all of the panelists. You know, what is the role of OCTA in these patients? And do I really need an ICG in any of these patients? When looking at the case so far, do you feel like you need one for that? And why do you need one? And then I'll talk about the treatment options in just a moment. So let's open up to the panelists and see what their comments are about that.
So I think OCTA can be helpful in some of these patients, especially when you see that little elevation there, to see whether it's associated with choroidal neovascular membrane as well, because as you know, CSC can be associated with some patients go on to develop CNBM along with CSC. So if there is CSC with CNBM, the treatment may be a little bit different than that without CNBM. So in that case, I do think OCTA can be helpful, but I do not think ICG is helpful. I don't usually use ICG for this type of cases.
Anand, any thoughts?
Yeah, I agree that, I mean, I would bring in OCT angiography if I suspect CNVM or a neovascular activity there. The course is not following the regular CSCR course. ICG, I now tend to do, fluorescein and ICG combined, so I do get them along. EDI, I think, really helps. I do not have a swept source OCT, so I rely more on EDI scans for CSCR. I'd like to look at the choroid as we all do.
Great. Great, Dr. Anand. So, you know, the treatment options are obviously quite diverse now. Obviously, if there's anti-VEGF in the setting of CNV, then there's a rationale to use this. There have been some case series and reports using anti-VEGF in the setting of non-neovascular CSR, but probably the more important data has really been around PDT, eplerenone, and micropulse laser. PDT, obviously, in reduced and full fluence fashion, has been validated in a variety of different retrospective series, the largest one being the Macular Society study. Eplerenone was studied recently in the Vici trial, and I would love to comment on this study. I think this is probably the worst trial design for any eplerenone evaluation we would have done. In this study, actually, patients were treated with eplerenone versus placebo and taken off the eplerenone after having response. So after 3 or 4 months, they were essentially removed from the eplerenone, and then they were waited to see what the outcome was. And lo and behold, at 1 year, patients were, off of eplerenone and had recurrences of fluid, which is what we don't do in clinical practice. When we treat with eplerenone, we treat the entire time, and I'll talk about that in just a moment. And finally, micropulse or traditional laser in this patient is an obvious issue. Just to touch a little bit on the pathogenesis, this is really quite review, but I'll talk to you about some of the more recent advances in this assessment of the pathogenesis. We know it's due to possibly choroidal hyperpermeability that then leads to retinal pigment epithelial decompensation, then forms these pigment epithelial detachments, and you develop then a break in the RPE, and you develop subretinal fluid as part of that process. And that develops the neurosensory retinal detachment. Probably the more recent spectrum is this pachychoroid spectrum that Billy Freund has worked so tirelessly on, where you essentially in pachychoroidopathy, you get non-specific RPE changes, choroidal thickening, choroidal hyperpermeability, and numerous scattered elevations in the RP in the sub-RP area. And here you can see those RP elevations in a patient with fellow ICSR and those sub-RP like drusen deposits in this patient. Again, the question I think in this case is why these patients develop choroidal hyperpermeability by ICG. And I think I have some recent data to show you that would show you why that is the case. In central serous, you'd obviously develop those RPE changes, the subretinal fluid with the serous PEDs, and you get this gravitational fluid, which is probably the pathognomonic case. And obviously in the late stage form is pachychoroid neovasculopathy, where you develop type 1 sub-RP CNVs, lipid and heme on the actual evaluation, and then polyps on the ICG. And probably the more recent data is this one. I don't know if you all saw this presentation, but it was a wonderful presentation given by Rick Spade at the Macular Society. None of the Macular Society was able to broadcast out. But what he showed essentially was, Hayray had shown us for a long time that they're vortex vessels, and that the ICG, if you look at these watershed zones, essentially the macula is the watershed zone or between these vertical and horizontal vortex veins. And in CSCR, essentially what you're seeing, or CSC, you essentially see intervortex venous anastomoses. And so what the reference here is that essentially that you get these pachychoroid vessels or intervortex venous anastomoses because of the fact that you essentially have a developmental abnormality in these patients. That this is an abnormality actually of the venous choroidal architecture, which leads to venous congestion, just like you would if you had a patient, for example, with the veins that dilate in the patient on their leg or on their arm. When you see those varicose veins, essentially it's in a very, very similar way. It's venous congestion. And that causes increase in back pressure in the choriocapillaris and leakage in the choriocapillaris and finally damage. So I thought this was a very keen assumption. And he did this with many patients looking at these pachy vessels and intervortex venous anastomoses in the patient. And again, the treatment for these patients is quite difficult long-term because no studies looked this out. Actually, this is our paper from the BJO looking at 3-year data on patients with eplerenone. Most patients actually had their anatomical response at year 1. And this is why I criticized the Vici study. I don't think it did what it should have done. And all of these patients were continued for 3 years on eplerenone therapy. While we didn't see a significant improvements in visual acuity, we didn't expect to see that because of the fact that they had good vision on entry and they had good vision on the end of the study. However, the anatomy was significantly improved, and they resulted in far less evidence of patients with subretinal fluid or of the height of subretinal fluid, even the greatest linear diameter. So really quite a good situation. Now, this is just the patient I treated in this case, and I decided between eplerenone and PDT, and I'd love to hear the panelists kind of think about this when I finish this talk and show you these last few slides. But essentially, I chose PDT because of the chronicity of this patient's fluid and the visual acuity drop-off that I was concerned about. And I did a PDT in this case. Here you can see the 1-month PDT follow-up. Again, the spot size for this, I have determined to be basically on the areas just to cover the leakage points, nothing more. I don't cover the actual PED component. I just cover the areas of leakage. And I've done that in this patient with reduced fluence PDT with quite a nice improvement in actually the OCT. But you can actually see on the IR image how much atrophy you have present in the fovea. Their visual actual improved to 20/80. This is actually now a year later. And this is actually even to 7 years later after their initial treatment in 2013. They're 20/80 in this right eye. Again, showing you a nice improvement in that subretinal fluid and no recurrences, not one more additional treatment of PDT here. And this is the right eye post-treatment, again, showing you 2021, just recently that came in to see me 20/80 vision in the right eye. And this is the left eye, again, with that subretinal fluid. Again, reduced fluence PDT was applied, and you saw an improvement in subretinal fluid. And here again, you see by 2021, the patient now 7 years after treatment has not received an additional treatment modality. So I just point this case out because I think it's important to show you that obviously there are a lot of options to treat these patients with. Probably they're very tailored to each patient's approach. And PDT is one of those things where it's not readily available, but if it is, it can be very effective. And certainly it obviates the need of continuous eplerenone therapy potentially in those patients as well. So I just thought I'd bring that case up, and I'd love to hear your comments about what your thoughts are on managing these sort of chronic patients.
So Rishi, you said because this patient was chronic, you chose PDT, but if it were not chronic, would you have chosen other different treatment otherwise?
Yeah, I think I mean by chronic in the sense that, Judy, there's some obviously outer retinal architectural significant changes in this patient where they've lost visual acuity and photoreceptor loss. Their lip side zone is totally destroyed or at least affected by this condition. If it was more intact, I probably would have chosen eplerenone earlier in this case. And I only chose, by the way, I only choose any of these therapies in chronic conditions. Chronic meaning greater than 4 months is defined by many of these trials and studies. But I think that the issue is looking at the outer retina, determining what the best course of action might be for this patient. This patient obviously has chronic damage and loss of visual acuity. And so I wanted something, in this case, that eliminated the fluid a little bit more. In my hands, at least, I feel like PDT eliminates the fluid faster and restores the outer retina faster in these cases.
So my definition of chronic is actually about 6 months, but I do see them in between to make sure that it's actually improving. If it's improving, then I continue to wait. But
I'm so happy to see that.
Half-fluence PDT works really well. For me, that's the way to go. It's one condition where PDT works like a charm. So I usually end up with half-fluence PDT for most of the CSC cases.
So Rishi,
Jay,
in case if you don't have the PDT for some reason, the verteporfin is not available sometimes here. And then do you recommend eplerenone, or what do you do about it?
So I've used spironolactone, I've used rifampin, I've used eplerenone. I've had the most experience with both spironolactone and eplerenone. Those are both eplerenone is pretty readily available. It's a potassium-sparing diuretic. But spironolactone is available. The only issue I've seen with spironolactone is I have seen gynecomastia in men. I've seen it twice. And so that's why I shy away from using eplerenone mainly in the male patients.
Jay, I think I just want to bring, we have done along with Jay also as part of the study, we compared a head-on trial eplerenone and PDT, low-fluence PDT, and it just come out in European Journal last month. Long-term results after 1 year results post eplerenone and post PDT, and we found that with single sitting of, as Dr. Judy rightly mentioned, we found that the people who were subjected to low-fluence PDT one sitting had no recurrence at all in this long-term results. And people who were if you read that article, we have completely given 6 months, not like VC trial. All of them received eplerenone standard dose 50 milligram for 6 months. Whether they responded, not responded, they were for 6 months. And then either patients who did not improve were lost to follow-up, or patients were withdrawn if it was a non-responder. So we found that it is far superior to eplerenone. Just wanted to add.
No, I think it's a great, I think, again, these studies, and Jay has done so much work here. Every time I go and look, it's like Jay Chablani has all these lectures given on this sort of topic. So, I think it's a wonderful area to look at, but the issue is, I think, long-term, even 6 months. So in your trial, you randomized patients to receiving just 6 months of therapy, or did you continue it all the way through?
No,
because
patients who responded were continued, and patients after 6 months who did not respond, they were not on the treatment anymore.
Yeah, so that's what I think that BJO article shows you, is that even patients at 1 year responded finally. And I think the timelines are slower, obviously, with eplerenone. I'm not saying it's the best drug. I think PDT is far superior. But I think that using eplerenone longer can actually make a difference as far as that.
So Rishi, one small query I had, excellent presentation. I also have a similar experience with PDT as well as Eplerenone, what George was saying. But one question which keeps bothering me is what is the role of verteporfin in this? Because verteporfin in ARMD binds to that lipoprotein receptors we know and enhances the laser uptake. But what in CSR? Why?
So that's a great question. So again, if the choriocapillaris has defects within it, that's all we're doing essentially is we're not treating the anything other than maybe the smallest choriocapillaris leak potentially. Or maybe if those vortex vessels that I just showed you, as Rick Spade adequately pointed out, if we're stabilizing them in some way, shape, or form with the PDT treatment, that would be the other way of saying that's working.
So
but you're absolutely correct.
What is supposed to bind at that receptors?
It's supposed to bind. It's supposed to essentially leak into spaces where it's not supposed to bind to receptors per se. It's supposed to leak into newer neovascular vessels, but it also essentially can find a leakage point. So, for example, you don't do PDT in a diabetic patient, as an example. And that's because of that the amount of permeability they would have in those cases.
So will this laser work without the injection of verteporfin?
No, I don't believe so. I don't think I've ever tried. The laser obviously is light activation for the verteporfin to actually change in configuration and block the vessel. That's actually what it's doing. But I don't believe it will work without any laser application.
No, without
I think, Dr. Verma, I think we are eating away Caroline's time.
Yeah.
I think that you all are able to see the timer, right?